All right, welcome. Let's get started with chapter 33, Pediatric Emergencies. This is a longer chapter, so buckle in. I'll do my best to keep it short and sweet and chock full of all the information that we'll need. All right, so as with most chapters, we'll start with a little bit of A&P, and some of it's going to be a review for our vital signs and whatnot there. All right, so kids are, first let's define pediatrics. It's kids, okay? So anybody from birth to 18 is a pediatric patient, or 18 and under, rather. Um, they're separated into several age categories. Newborns and infants are from birth to 1 year. Newborn is considered a newborn for the first month, and then that's an infant for after that. Toddlers from 1 year old to 3 years old. Preschool age is from 3 to 5 years old. Let's remember that as a child grows, their vital signs change. Um, there is a large chart in the book that goes over all the different ranges of vital signs, from blood pressure to heart rate and respiratory rate. It's difficult to remember all of the different vital signs for each age. So it's recommended that don't rely on your memory for it. Now, be aware of it, but don't rely on your memory for it. I would definitely like you to go through and look at least at those different vital sign changes through the ages there, so you can be aware of how they're changing. Now, a lot of places will have handheld protocol booklets, or you can even like save a picture into a folder, marked like EMT or something like that on your phone. That'll that'll show like vital sign charts, something handy for you to use while on a call. As a general rule of thumb, what you're going to see from kids, pediatric patients, is a higher heart rate that slowly, as they age, comes down to that normal 60 to 100 range by the time they get to about 18 years old. And then you're going to see a lower blood pressure that slowly over time raises and gets to that 120/80 that we want around adulthood there, around 18 years old. Let's see, as we know for kids, what is it? What is that formula for estimating a kid's blood pressure? Hopefully you remember that it's 80 plus 2 times their age, and that should generally give you their systolic blood pressure there for where it should be. And it's basically for anybody around 5 and under, basically, that you can use that for. You can also use it for, they'll be a little bit older too, but generally speaking, it's for the younger kids there. So make sure you go over the chart showing the vital signs there. Be aware of how it changes. The breathing rates, they also are fast and slow down as we get older. Their heart rate is fast, slows down as we get older, and the blood pressure is lower and comes up as we get older. So go through that and make sure that you know what it is that they're talking about there, and have a general idea of how those changes occur for kids. Okay, for some anatomy and physiology review here on the pediatric anatomy. We know from previous chapters and previous things that we've learned that there is a difference between an adult's anatomy and a child's anatomy. So a few things should pop into your head right away. That their heads are bigger, their airways are relatively speaking smaller. Their tongues are, relatively speaking, larger in their airway. The mouth and nose airways are more easily obstructed. The trachea is more flexible. It's narrower, so it's easier to get things stuck in there or be obstructed by swelling, things like that. The chest wall is softer, it's more pliable there, and it's not as muscular. And so kids rely more on their diaphragm to breathe rather than their chest walls like adults do. Um, their their thorax is shorter than adults, and they've got a very full abdominal cavity there with all those vital organs in place, and so obviously that can make a difference with trauma there. So there are some differences. So if you need to go back to the A&P chapter and review some of those differences there, we've got several pages of good review in this chapter. So make sure that you go through and you touch on these things again. Again, it's review for things that we have already learned. All right, let's touch on a couple of things with the head here for the pediatric patients. The head is proportionally larger and heavier than adults until about 4 or 5 years old. So that means that they are very susceptible to injury, especially if the mechanism of injury looks severe. It doesn't even have to be that severe to get the forces to be applied to their body to get that head moving in direction so we can get neck injuries. Also, if you remember, there's things called fontanelles. They're the soft spots on the infant's heads. Generally, there's two large ones that they have. One's on the back of the head, and that is usually closed up by the time, or like it's fused. The bones are basically fused by the time that they're about 2 to 3 months old. But the big one right on top of their head, the anterior fontanelle, generally speaking, for most kids, that is not completely um, closed. It's not completely closed until they're about 2 years old, and so it's good to you'll be able to see that in younger kids. Now, for maybe about half the kids or so, by about a year or so, it is closed there. But generally speaking, about most kids have it closed by 2. What's normal is it's a soft spot and it's kind of flat on the top of their head. Now, if you have a kid that's really crying there, you'll see it kind of bulge a little bit. You'll see that kind of bulge, that fontanelle, while they're crying. That's normal. So you'll see kind of like the top of their head kind of come up a little bit. That's totally normal. Now, if you have a soft spot, that fontanelle there, that's sunken, that can indicate severe dehydration on the kid there. And then if the child has a bulging fontanelle and they're not crying, it could indicate elevated levels of intracranial pressure, so pressure inside the head. So maybe the kid's had a head injury. As we said, with the airway and respiratory system, the mouth and nose are smaller, more easily obstructed. The tongue takes up more space in the mouth there. As we talked about in other chapters and our last chapter, kids and infants, they are obligate nose breathers. It's a skill that they have to learn to breathe through their mouth. Which means if you got a kid that is he's got a really nasty head cold and he's a year old and he's completely congested where he can't breathe through his nose, then he could have a real problem breathing there. So suctioning, being aware of having maybe to suction the nose there a little bit with a bulb syringe, that may be a good thing to do there. So remember, kids are obligate nose breathers. They typically breathe through their nose. Windpipe, softer, more flexible, it's narrower, and so it gets obstructed more easily by foreign objects, food, toys, coins, whatever it might be, and swelling. If airway starts to swell, well, there's just not as much room for it to swell because it is smaller. So those things can have an effect as well. We talked about the chest wall being softer, and so they're more dependent upon their diaphragm to breathe. They don't have the muscle buildup yet to rely on their chest walls to breathe as much as adults do. Remember, by the time they're born, they haven't used those chest muscles at all to breathe. The first breath they take, first work those chest muscles get is when they take that first breath. So they are dependent upon that diaphragm there. The thorax is shorter. The abdominal contents, they're part of the reason why kids have these big bellies is their abdomens are just full of their organs there. And it can, because they're so full, things like that, it can prevent that diaphragm from moving downward as it contracts. It prevents them from getting like a deep, full breath there. So the neonate ribs, they're more box-like than kind of rounded. They grow into that. It limits their abilities to take deeper breaths. As we talked about, infants are obligate nose breathers, so if you do have to suction, use a bulb syringe to suction the nose there, and that's the reason why we suction nose, then mouth first when we're assisting with the birth of the baby. Now, as we talked about in CPR, if you remember way back when we learned CPR with kids, the hyperextension of the neck, which is the neck going backwards, like if you're doing a head tilt chin lift, and if you did it too far, that would be hyperextension. That can close the airway off. Hyperflexion of the neck is when the head comes forward and down. And that can result in airway obstruction. We can hyperflex our own necks and feel a bit of airway obstruction there. So if you put your chin down to your chest and try to take a deep breath, you can feel like the pressure on your own airway like that. So but ours have those nice cartilage rings, right? Those nice 16 cartilage rings, those incomplete rings there to keep our trachea open. Well, the kids, those aren't solidified yet. It's much more flexible. And so when you hyperextend a kid's neck or there's hyperflexion there, we can have airway obstruction. So we talked about finger sweeps for the choking patient, if you remember that. And that's, putting your finger in somebody's mouth to remove an obstruction. Now, we never do a blind finger sweep on anybody, but you really got to remember that from kids because that airway is just so small. We could push that obstruction further down. Say there's like a Lego back there or a coin or something and you can't see it, but there's something back there. If you stick your finger down there and try to sweep, feel something, get it out of there, you might push it further down. And it can get blocked in, wedged into that trachea that, again, is much more narrow than an adult's. So no blind finger sweeps. Here's a picture that we've seen several times throughout the book, demonstrating the differences between the adult and child airway differences. All right, let's talk about the chest and abdomen. The chest for pediatric patients, it's less developed and it's more elastic in kids. So it's less developed, meaning that there's less muscles in that chest wall there. It makes kids be abdominal breathers. They have to use some of their abdominal muscles to help them breathe. They're more dependent upon that diaphragm there. The chest being more elastic, it's the ribs. The kids' bones, they're like rubber. Kids bounce, right? And when it's a great design because as soon as they start walking, they start falling a lot, and they continue to fall for many years. But that chest, it's more elastic there. It's less rigid. It's less developed. Abdominal organs, since they're so packed in a small space there, they are less protected than adults. As we know, the kid's body surface area, in proportion to an adult's, they have a larger body surface area than an adult does compared to their mass. Um, it's difficult for them to maintain their body temperature, and so they lose heat through their skin really easily, and that makes them more vulnerable to hypothermia. It's one of the reasons, I mean, other than to stimulate the baby, it's one of the reasons why we immediately dry off the baby after they're born, right? Got to get them all dry. They're losing heat. Put that little beanie on top of their head to keep the heat in their bodies, help them maintain their body temperature there. So they have a larger surface area compared to an adult's. They're more prone to losing heat through their skin, and they're more vulnerable to hypothermia because they can't regulate their temperature as well as adults can. This should be considered kind of like a, oh, well, yeah, duh kind of slide. Kids have less blood than adults. Shocker, right? The blood loss for an adult that might be, not so bad, could be kind of serious for a kid, right? So let's take just your size and body mass, and you compare that to, say, I don't know, a 3-year-old, right? You've much larger body, a lot more mass there, and therefore you're going to have a lot more blood. There's a lot more vasculature running through your muscles and your organs and your skin and everything else that you have that those kids just don't have. So a moderate amount, as it says here, of blood loss for an adult could be a serious and life-threatening situation for a child. So anytime that we've got anything that looks like serious bleeding from a child pediatric patient, immediately treat for a shock. Here we can kind of see, just it gives you a general idea of the blood volumes that are in people by age range there. So if you have a 9-pound newborn, it's about a 12-ounce can of soda. Um, so not very much, and that's a 9-pound kid. So which is just nuts, right? That's not a lot of that's not a lot. So if you got premature babies or just smaller babies, that's a lot less blood. About a 60-pound kid, so that's going to be like in the probably like the 6, 7, 8-year-old range, around there. About a 2 liter of soda, and an adult at around 125 pounds is going to be about 2 liters. Obviously, you get bigger folks, you're going to have more blood. So, but that's about a 125-pound adult. Along with anatomical changes that occur when a child is growing, there's also psychological and personality changes that occur as the child is growing and that you need to be aware of. Each group has its own general characteristics of psychology and personality. The book does a really good job. It's got a good chart, it's table 33-3 in there, explaining some of the general characteristics that you can expect. Not only the general characteristics, but some of the assessment techniques that you may want to use with those different age groups. Like, for example, if you're assessing an infant, you don't really have to worry about the infant's modesty if you have to, get them trauma naked or, take off their clothes to examine them. You would, however, for, a 9-year-old. So there's differences there in how you would handle things. So table 33-3 in the chapter does a really good job of going through that. Be aware, obviously, that when you walk into a scene and you've got a young kid there, some kids may cry when they see you. Some kids may not like it when you have to touch them because you're a stranger. You're strangers walking into their house. Mom and dad might be upset, and so they're kind of feeding off of that. The big lights and stuff, they might be scared of getting in the ambulance. Some of those big diesel trucks are loud. Um, so that's going to happen, all right, and that's normal. You have to be aware of that, but at the same time, you can't let it stop you from giving them the appropriate patient care. You can't let them being upset um, stop you from doing that. Let's go over quickly some of the personality traits and characteristics that we might see from some of these kids. Newborns and 1-year-olds, they typically don't have any problems with strangers, right? Up to about 1 year old, maybe just a little younger than that. They don't. A lot of times they won't have any separation anxiety, meaning like you may be able to hold them and they won't. They won't freak out, right? Things like that. Um, Younger infants, after about it's about 2 weeks or so, if I remember correctly, they're able to track movement with their eyes, and so obviously they're not going to be able to talk to you and things like that. But one of their normal findings for them is that they're tracking movement with their eyes. So you can kind of look at that as kind of like an AVPU thing. Like, how are they? Are they alert? Basically, they're not going to be able to talk to you, obviously, but if they're tracking well with their eyes, that's a really good sign. Older infants, obviously, they're going to be more active. They'll have some bit more of a personality. One of the patient care things that you should remember here is these young kids, they do not want an oxygen mask on their face. They are not going to want it. That has been my experience in dealing with pediatric patients. It says it in the book. Just about any kid is not going to want that oxygen mask. And then when I say kid, I mean like a younger child, right? Let's say 5 and under. You might not, they might not like it older than that too, but you'll be able to put it on most of them. But infants, things like that, they are not going to want it. So you're going to have to do some blow by there. Some other assessment stuff for those kids there's you don't necessarily have to hold the child. Have mom or dad hold them. That may help keep them calm, and you can assess them when mom and dad is holding them. Again, don't worry about if they're screaming or crying, things like that. That's a good thing. That normally with kids, like we want to hear them crying, especially if they've been hurt. If you have a hurt child and they're not crying, that's a bad sign. Remember, breathing is super important for these kids, and we'll talk about that a little bit later. So always make sure that you can see their work of breathing there. And generally with younger kids, we're going to start basically at their toes when we do a physical assessment and work up to their head, do the head last there. Toddlers, so this is going to be about 1 to 3 years old. All right, so these kids have separation anxiety. They have anxiety about being with strangers. They don't like to be touched by strangers, things like that, and that means you. So it is more difficult to assess them. So you're going to have to work with mom and dad here. Have mom or dad hold the child there, comfort the child while you do your assessment, if that's possible. Kids don't understand a lot of things here, right? They just don't have any life experience to compare anything with. And so they may think that because you're there, because this whole big deal is happening and mom and dad are upset or crying or they're putting off this energy, that they're worried or whatever it might be, they may think that they're in trouble, that this whole thing, whatever is happening, like, oh, they got hurt and now they're in trouble and these strangers are here at the house. They could think like, they could feel like that they're in trouble. So assure them that they're not in trouble, things like that. That can go a long ways. Now, when you're doing your assessments, they're probably not going to want you to take off their clothes to do that, right? This is another part of the stranger anxiety, so try to have mom and dad do that if they can. They may frighten or overreact really easily, so just be aware of that. Now, if you guys don't have experience with toddlers, they are going to understand a lot more than you realize. Okay, so when you communicate with them in words that they are going to understand there as best you can. Okay, but they may not be able to communicate as much, but they're going to understand a whole lot more than you think. So communicate with them and use words that are on their level. Again, use the toes to head or trunk to head approach to assessing these kids, right? Do the head last. You can explain things to them, like if you're taking their blood pressure, just say, this thing is going to give you a hug on your arm. there. So use it in terms like that. You can also give them choices, so they feel like maybe they have some control, like, oh, I'm going to take your blood pressure. This just gives you a little hug on your arm. It's okay. Let them touch it and then be like, which arm would you like me to do it on? Give them a choice in the matter there. With preschool, that's 3 to 5 years old, preschool age. Right? They don't want to be, they're not going to want to be touched. They're not going to want to be separated from their parents. So there's high levels of anxiety there. These kids this is where you're going to start to see that they're going to have a fear of pain, of blood, of permanent injury, things like that. Now these kids, they can be communicative. They're going to understand a whole heck of a lot. They still may think that they're being punished for everything that's going on right there, that they're in trouble there. And so these kids and the toddlers, they could be just little liars, right? They could just be little liars about things because they think they're getting in trouble, or they don't know what to say. They're overwhelmed by the situation, the anxiety, things like that. So they're not the best reporters for their own health. Okay, so most of the information we're going to get from mom and dad. So, these kids can be liars. And it's not that they're lying to you on purpose to get away with something, but they may. So just be aware of that. Again, they're probably not going to want the oxygen mask. You're going to do the trunk to head approach to assessment there. Be honest with these kids, right? These 3 to 5 year olds, okay? Again, talk in terms that they're going to understand. Your tone, your demeanor, it's going to mean a whole lot to them. So be calm, be reassuring, things like that. Be aware that they may be immodest. So if you have to remove their clothing, replace it when you're done, or cover them up when you're done, okay? Again, they're probably not going to be impressed with an oxygen mask. They're not going to want it on their face, so blow by, again, might be necessary, although you might be able to get one on one of these kids' faces here. Kind of explain things as you're going. School age, 6 to 12 years old. They cooperate, but they do. This is where kids are starting to form opinions and be able to express them in ways that they've never been able to before because of cognitive development. So they're going to want to kind of be a part of the process here. So give them choice with things. Which arm do you want me to take the blood pressure with? Give them maybe some of the responsibility. Ask them questions, more questions of this patient than you would the preschool patient. You probably get a better history out of that. They're probably not going to be thinking as much, generally speaking, that they're getting in trouble here, then that's why you're there. Again, be confident, be calm. Your demeanor is going to mean a lot. Explain what you're doing to them there. Adolescents, so 13 to 18-year-olds, they want to be treated like adults. Now, adolescents, there is fear of permanent injury, of blood, and things like that. However, they are impulsive. Adolescents can be impulsive, and so they may do things where that fear of injury and blood and whatnot is not really there. Adolescents can be very emotional. If they're going through puberty, things like that, where there's different hormones, there's different cognitive developments, things like that going on. There can be real emotions there, so be aware of that. They're highly influenced by their peers and what they think. They're starting to separate from adult authority figures like parents, teachers, things like that. And you're going to be there as an authority figure there too. So just remember that. So again, they want to be treated like adults. They want it to be, you should be, as with anybody, calm, be respectful, explain what you're doing there. Avoid causing them any kind of embarrassment, so respect their modesty, give them privacy, things like that. You know, if you need to clear a group of friends or bystanders away from them while you're doing an assessment, get them out of the scene, or move that patient to the ambulance first, then get that done. Just be aware of that. So lots of general characteristics. There's a good chart, table 33-3 in the book there. So just be aware of the different techniques and approaches that you should have for different age groups. All right, so think about it. Go through, look at that chart, and then answer the question for yourself. What techniques would you utilize when attempting to assess a crying infant? Is the crying good or bad? Things like that. All right, let's talk about interacting with these kids. When you're doing this, you want to identify yourself. Um, Let them know that you're there to help. That you're not there to get them in trouble. If um, if if the situation doesn't demand speed and movement immediately, then be calm during your evaluation process. Not only is this going to really help with the kiddo, it's going to help with mom and dad also. That is going to help you a lot through this process. If you can get mom and dad calm and have them put their trust in you, like, oh, she knows what she's doing, right? Or, you know what, he's got this. I can tell he's got this. Then the baby, that child, is going to feel mom and dad's energy. That they're like, oh, this isn't so bad. Mom just calmed down when she's talking to this guy. This guy must be all right. Oh, mom just calmed down. She's not crying anymore, and she's talking to this lady. Like she must be okay. She's going to help me. All right. So calm demeanor there. Calm professional demeanor there. If they have a toy, let them have the toy. This is important. The kneeling, being at your patient's eye level. Okay. You are like a towering giant if you're standing in front of a little kid, right? So let's get down on their level. Let's talk at their level. Let's be calm and reassuring for them. Smile, be affable with them. Touch or hold a child's hand and foot. What that means is like get them used to you touching them first, but away from their body and especially away from their head and face. Um, it's kind of like letting a puppy smell your hand first before you pet it, right? So touch and hold their hand or foot first before you can do the other assessments there, especially before you touch their head. If you've got any equipment, let them see it. Explain what you're using it for. If it's a stethoscope, please warm the bell before you put it against their skin. Rub it on your shirt, warm it up, things like that. Obviously, let the child see your face. Uh, as with anything, when you're explaining something to somebody, stop and figure out if they know what's going on. Okay. Don't lie to the children, especially the older kids, right? Once you start getting to school age there, and then obviously adolescents, don't lie to them. I'm sure you all have BS detectors that are fully operational at this point, right? So your patients are going to have that too. So don't lie to them, okay? If you do, and they uh, they figure that out or they sense it, then they're not going to trust you. And that's going to make your patient care a lot harder. Think about a time where you've been getting customer service or something and you think that person has lied to you. Did that immediately change your opinion of your interaction with that person? Did it immediately color it in a way that it wasn't good? So I'm sure everybody's had an interaction with somebody in a customer service situation where you've been lied to, or you at least felt that you were being lied to, and it colored the rest of that interaction. So remember that when you're talking to kids. Uh, as we talked about with adolescents, 13 to 18, they should be able to tell you exactly what happened and how they feel. Um, if Here's a big thing, they may not be completely communicative or cooperative if they're in front of their friends and family. It could be an embarrassing situation in front of their friends. It could be a situation where they think they might get in trouble in front of their parents. Let's use, for an example, what if you're talking to a 14-year-old girl who has lower quadrant abdominal pain? What kind of questions do you think we have to ask a 14-year-old girl with lower quadrant abdominal pain? And just to rule out an appendicitis, let's say it's left lower quadrant. All right. What kind of questions do we have to ask? Well, if you remember back to abdominal emergencies, we're going to have to ask any female of childbearing age questions about if they could be pregnant or not, when their last period was, have they missed a period, is there a chance that you could be pregnant? Do you think a 14-year-old girl might be completely honest with you, with mom and dad in the room? Maybe not. Probably not, right? If something embarrassing happened and there was friends there and they didn't want to be embarrassed with their friends around, do you think the kid might be, or that adolescent might be less apt to tell the truth? Yeah, they might be. They might be. So keep that in mind there. So even if they are embarrassed or they're not, you think they're maybe that you may have a concern that they're not telling the whole truth, don't delay your transport or your treatment because of that. Now, this last point is important here. If you need to remove clothing and examine a person, particularly if you're going to remove clothing and see their genitals, or if it's a female and you need to remove their top as well, make sure, do your best to make sure that a same-sex EMT is doing it. Okay, obviously everything has to be above board, but this can help ease patient anxiety with a same-sex provider there. So if it's a female patient, have a female provider do the assessment there. All right, this is an important thing. We just kind of touched on it there. Supporting the parents or other providers. So supporting mom and dad or whoever the caregiver might be there, maybe it's grandma or aunt and uncle, something like that, is incredibly important. Um, Now, when a kid gets ill or injured, the parents or whomever it may be, there can be a lot of reactions there. Denial, it can be in shock, surprised, complete disbelief there, not actual shock. Crying, screaming, they can be really angry, that can be self-blame and guilt. There can be a lot of stuff going on there, and that may actually interfere with you giving care to the child. You might have to work to gain their trust there, so by asking good questions, being calm, using a professional demeanor, things like that. If after a while um, uh, you can't get mom or dad or whomever the caregiver may be to stop interfering with the care that needs to be given to the child, have another family member maybe remove them from the scene and take them into a different room if possible. Do need to be aware that not everybody grows up in that traditional nuclear family, meaning that mom and dad are living in that same house. I think many of us in over our two classes can say that isn't or wasn't the case for us. So be aware of that. So you may have to ask the question like are you mom or are you dad or are you the child's caregiver? Like who are you basically? So be aware of that. Be tactful. there. So it may be a good question to ask instead of just assuming somebody's mom or dad. Just like, are you mom or are you dad, or who's this? Who's the parent, or who's the caregiver? That kind of thing. Uh, Again, you can get mom and dad to help. I know from experience that if you can feel helpful during a child's illness or injuries, like it's much better than feeling helpless. So you can ask mom or dad or whomever the caregiver is to hold the child, comfort them, help you with the medical history or the injury history, what happened there. Um, just little things like that can help ease their mind. You can help gain their trust, and if you can get mom or dad or whomever the caregiver is to kind of believe in you, to trust in you, to calm down a bit, then the child is going to feed off of that as well, and that can make the whole process better for everybody. Here we see mom giving a little blow-by oxygen to the kiddo there while she's holding the kiddo there, and the caregiver is down on on his knees, or he's lowered. He's at the child's level there. He's at a little bit of a distance off, and he's not touching her or anything like that. So, gaining trust and support, letting mom help there, all good things. All right, let's talk about assessing the ped. Okay, for pediatric assessment, we're going to use the pediatric assessment triangle, the PAT. And for this, we're going to take two looks at the at the kiddo there. The first is going to be from the doorway. And this basically means your general impression. Okay, we're going to try to get a lot of information um, through our general impression there. And and the reason we do it at the doorway is because maybe your presence right next to the kid changes things. Maybe they're more hyper, more maybe they're crying, more things like that. So it may change your ability to assess some things once you get there. So it's from the doorway. It's when you walk into the room. It's your general impression that you're getting, and we'll touch on that a little bit here in a second. The remainder of it, the assessment, it's done basically normally next to the assessment. So the PAT, we kind of take two slices of it, one from that general impression standpoint, and two when you're getting your primary assessment done. There's three elements to the triangle, so three corners to that triangle, right? We all know what a triangle is, hopefully. Um, so the first is their appearance. All right, so what does that mean? Are they acting appropriately? Do they have good muscle tone? Are they interactive with the world around, the environment around them? Are they interactive with their parents? Are they watching you walk into the room? Are they tracking things with their eyes there? Um, Work of breathing. Obviously, we want to see, or what we don't want to hear anyway, is noises, right? So we want that good, clear breathing. We want ease of work there. We don't want them to be working too hard. So keep an eye out for. Are they struggling to breathe? Are they trying to position themselves? Is a like a toddler or infant really restless? Is that them trying to get into like a kind of a sniffing or position or something like that to help them breathe? Are they lethargic? Do they have stridor, wheezing? Are they grunting when they're trying to breathe out? Things like that. Are we seeing seesaw breathing, nasal flaring, any retractions, anything else like that? And then the last is circulation to the skin. So we're going to be looking for certain things. So circulation to the skin, what are some of the things that we can look for? Well, we can look for pallor. Are they pale? Are they cyanotic there? And so that's all we're looking for there at the doorway there for circulation to skin, or just basically their skin coloration there for that. All right, so with anything else, like with any other call, we're going to determine if the scene is safe. Um, uh, be aware that that sometimes when kids get hurt, it's because of physical violence, and sometimes it can be in the home, domestic violence, things like that. Abusive behavior, so be aware of that. Obviously, use your standard precautions. Never get off your rig without your gloves on. You're a crazy person if you do. Well, just my opinion there. Um, Obviously, look for environmental hazards to yourself, anything in the environment that could have harmed the child for a mechanism of injury or things like poisoning, that is. Here we have a look at the pediatric assessment triangle there. So circulation of skin, work breathing, and appearance. Okay, so for primary assessment with pediatric, now a lot of these things are going to be the same as adults. All right, forming a general impression with any patient, hopefully you're able to rapidly identify a critical patient. Okay, um, and as with any other patient, the general impression it's an essential component for that. So make the following observations: mental status, interaction with the environment, others, and emotional state. All right, so how are we going to get the mental status of an infant? They can't talk to us, they can't answer questions, things like that. So how are we going to get their mental status? Well, that's how we see when what we're looking for when they're interacting with the environment or others. There, we check in on their emotional state. Are they lethargic? Are they hurt and they're not crying? That would be a big tell right there, right? Like little kids when they get hurt, they cry. So could their mental status be off if they're hurt but not crying? Absolutely, sure. Are they interacting with the environment? What's their muscle tone like? Are they limp? Are they groggy? Things like that. That can give you an idea of their mental status there. For the primary assessment, for the pediatric assessment triangle, rather, um, from the doorway, forming your general impression there, the doorway view, we're going to be concerned with the A and V of AVPU. We can get that from the doorway, basically, or walking up to them, right? Are they alert? Or, are they alert to verbal? Is mom or dad saying anything? Are they loud enough to stir the child? Things like that. We can get that from the doorway. Another thing for mental status, like, do they respond to us if they're really, really young? If they're an infant, maybe they're just tracking us with their eyes. They're looking at us. Again, tone, muscle tone, body position. We're looking at their work of breathing. What's their quality of their breathing along with the work? So are they crying? That could be a good or a good sign there. Or the quality of their speech. Are we hearing any noises? Again, like crowing or stridor, wheezing. Are they grunting when they're breathing out? And then we're looking at their skin color. Again, we're looking for any like mottling or cyanosis, pallor, anything like that. All right, this is all under general impression. This is in the first few seconds of when we're walking into the room and we're absorbing all this information as we're looking and listening to what our patient is doing. All right, so a couple of things here, a couple of points. Look at the chest for even expansion. Remember, kids are oftentimes belly breathers, so you can look for that going up and down there. Are there sounds coming out of the mouth? If it's stridor, that's an upper airway obstruction. So is it an object that's in there, or is it swelling, wheezing, things like that? Would be lower airway, obviously. So some things in here to think about. All right, so we know what the AVPU stands for. So are they alert? Are they alert to verbal stimuli? Do they become alert because of painful stimuli? Or are they unresponsive? To For the unresponsive child, we're not going to really inflict a lot of pain there. So all we got to do really is, especially the infants there or very young child, we can flick the bottom of their feet. Like we don't have to, um, you know, pinch the trapezius muscle back there. Don't really have to pinch the ear or things like that. Just you can tap the bottom or flick the bottom of the patient's foot. As with any patient, we've got to assess the airway. So what are our two questions for the airway? Is it open? Will it stay open? If it's not open and you have to open it, and you use a head tilt chin lift, if you don't suspect any trauma and you use the head tilt chin lift, beware not to hyperextend it, right? We talked about why we don't hyperextend the child's neck, right? The trachea is much more flexible, can close in on itself when we hyperextend. So be careful not to do that. So this is just a picture showing you what we're assessing when we're looking for like their breathing there. All right, so for breathing, we want to see good chest expansion. We want to see an ease of the work of breathing. We don't want to see them working hard to breathe. What are some signs of pediatric difficulty in breathing? Some respiratory distress where they're working hard. Well, we'll see things like nasal flaring, retractions. We may hear grunting. That can be kind of thrown into sounds of breathing, whether they're working to get that air in and out. What's their breathing rate like? Right, it's going to be higher anyways, but is it higher than what should be normal? Um, Again, we talked about breathing problems, wheezing, stridor, crowing, all those things. Look at their color. How is their skin color? Are they pale? Are they cyanotic? Are they washed out? Are they mottled? Things like that. Looking at the circulation, obviously, again, just comparing their skin color. When you actually get there and you're able to put your hands on the child and assess a pulse, um, is it a normal pulse? Is it strong? Is it regular? Um, Cap refill is great in infants and kids under 5 there. Obviously, as with any patient, check for and control any blood loss. You can see here in this picture the provider's kind of squeezing down on the palm, or the posterior aspect of the child's hand. There, you can see how um, it's squeezing the blood out of the capillaries. How the back of the hand there is whiter compared to the rest. So you can press down on that, let it go. Should fill back up and become nice and pink there. All right, identifying priority patients is pretty simple here. It's going to be just like adults, basically, with a couple key things to remember. So any patient that's got a compromised airway is obviously high priority. If they're in respiratory arrest, if they have inadequate breathing or they're in respiratory distress, this child is going to be a high priority patient. And here's what we got to remember with that. The number one cause of pediatric cardiac arrest, respiratory and airway issues. So if we have those, that makes them a high priority. If they have the possibility of shock, again, just like an adult, they're a high priority patient. And you've got to remember that a child only has to lose a little bit of blood in order to get to a shock state. So they'll be high priority. And any uncontrolled bleeding, or if the bleeding has been controlled, but it was a significant amount that was lost, again, leading to a possibility of shock before EMS has arrived. Um, In the secondary assessment, just like an adult, we want to ask open-ended questions, right? That preferably can't be answered with just a yes or a no. The physical exam for a medical patient, that's a pediatric patient, is going to be just the same. We'll do a focused assessment in the areas where the systems affected are. And the rapid trauma assessment will be the same too. You want to explain what you're doing to the child. Just like an adult, you want to explain what you're doing. Remember, we're just going to have to maybe change our words a little bit so they can understand, depending on their age, exactly what we're talking about. And obviously, we're going to record vital signs. We're going to trend those as well. Speaking of vital signs, and this picture here where they're taking a blood pressure, we want to take blood pressure on kids that are 3 or over. It's going to be most reliable for those kids. Now, when we're doing a physical exam, if we can, time isn't greatly of the essence there. We're going to start with the toes or the lower abdomen first and work our way towards the head, and this will help keep the child comfortable for us. That probably when some stranger just reaching out for their head right away, right at first. So start with the toes, work your way up there. If there's no injuries, let the kids sit in the parent's lap, buckle them in safely and everything, but let that pediatric patient sit with mom or dad to help them be more comfortable. Just like with any other patient, protect their modesty. So if you have to remove a piece of clothing, explain why. Like if there's an injury to a leg and you have to take their pants off, explain why. And then once you're done, cover them back up. Either put the clothes back on if you can, or cover them up with like a sheet or a blanket. All right, when we're doing a assessment on the head, if this child is less than 2 years old, let's be real careful around the fontanelles, those soft spots in the head. Don't apply pressure there. A child with meningitis or head trauma can display bulging fontanelles. Now, this is when they're going to be at rest, not like actively crying. They're just at rest, and the top of their head is bulging there. Meningitis is an infection, so there's going to be swelling associated there. And head trauma, we're thinking about that there's intracranial pressure that's building up because of a bleed inside the head, and that would cause the bulge in the fontanelles. As we'll talk about a little bit later, some of the trauma stuff, we can see that collisions, motor vehicle collisions, and whatnot can often produce head injuries for these kids, and we'll talk about why a little bit later. All right, nose and ears, just like an adult, we're looking for CSF. We're looking for blood coming out. We're looking for clear fluid coming out, and we can always do the halo test to check on that. You should remember how to do the halo test there. If we do see either of those things, blood coming from the ears or clear fluid coming from the ears or nose, then we should need to suspect a skull fracture. And remember, younger kids, they are obligate nose breathers. They have to learn how to breathe through their mouth. So if they do have obstructions in their nasal passages there, it's going to make it hard for them to breathe. So if there's mucus or blood clots, things like that, we may have to suction those out with a bulb syringe. Here we see a nice little picture of a little baby. They're not going to be tolerant of a non-rebreather mask on their face, and so the EMT has got the oxygen tubing, and they're doing a nice blow-by of O2 by the child's face. That oxygen is going to be flowing right past her face while she's breathing, and it's going to be a nice way to provide some supplemental oxygen to the patient who won't accept that non-rebreather mask on their face. All right, just like adults, the neck is vulnerable to spinal cord injuries, especially these kids with these giant noggins, right? They have proportionally larger heads, they're heavier, their neck and supporting systems aren't as developed, like the muscles aren't developed there, the muscles and the bone structures are weaker than adults there, so it's much easier for them, because of these giant melons that they have on top of their shoulders, to get neck injuries there. So we can see, just like an adult, sore, stiff, and swelling tissues in the neck. Here we see something that's important. So with younger children who have these bigger noggins, right, these giant melons up there, they're proportionally larger heads. When an adult lays down on supine, the head will generally be in a neutral position looking straight up at the ceiling. With the child, because their heads are proportionally larger, when they lay supine on their backs, it actually pushes their head forward. We have a little bit of flexion going on there. The head's going forward, the chin's going down towards the chest. So in order to combat that and prevent that from happening, what we can do is place a towel underneath their shoulders. So it kind of raises the level of the body a bit, lets the head sit back, and allows it to be the airway to be aligned in that nice neutral positioning that we can see here. So this is important for the younger kids here. I don't know, just judging by this kid, he's probably about 4 years old, something like that, 4 or 5 years old there. So it's important to remember this when you're working airway for these pediatric patients. You may have to put a towel, some sheets folded up, whatnot, underneath their shoulders, prop them up a little bit to help get that nice neutral alignment. Speaking of neutral alignments, when we're doing that, we want to maintain that neutral alignment for infants. We're just past neutral. That's what they call neutral plus. A little bit of a sniffing position there for children. Remember, their trachea is much more flexible, and so if we go too far, if we have that hyperextension of the neck there, then we could close off the airway a bit. So maintain neutral plus, a neutral position or neutral plus positioning there for the children. And just as we were explaining the slide before, if we don't suspect any trauma to the spine there or a spinal injury, then go ahead and place that towel underneath their shoulders to get the appropriate alignment there for the airway. All right, chest, just like adults, be alert for noises. Okay, check for symmetry. We don't want any paradoxical motion. We want equal chest rise and fall. Look for any bruising or anything that looks unusual in the symmetry of the chest there, of the body. That can point to underlying injuries. Look for retractions as well there between the ribs and then up above the collarbones there. And that is a suggestion, obviously, of respiratory distress. Abdomen, just the same for the most part. Note if it's rigid, if there's tenderness, if there's distension. Look for those. We're going to palpate in just the same manner as we would an adult. Now with the child, though, because the abdomen is pretty packed, it's relatively small compared to the adult's abdomen. Those organs kind of press up a little bit against the diaphragm. So if we have injuries, if we have swelling, if we have bleeding, if we have distension in the abdomen, then that may prevent the movement of the diaphragm. When the diaphragm contracts and moves downward to help us take a breath, it may prevent that movement. So be aware of that. You may have to provide ventilation for the child because of an abdominal injury. Pelvis, we're going to check it just the same. We're going to close that big book to check stability there. Extremities, it's going to be just the same as adult, except we're going to go throw in cap refill there. Okay, so we're going to check for the distal pulses, motor function, and sensory function, and then we're going to check the capillary refill as well. Reassessment, just the same as an adult. We're going to reassess mental status, make sure that airway, we're going to ask ourselves our 2 questions. Is the airway open and will it stay open? We're going to monitor the breather. We're going to make sure that it's at a good rate and depth. And then we're going to reassess the pulse, make sure it's nice and strong and in the appropriate range. Skin color, temperature, moisture, all the same as an adult. We're going to check that. Vital sign reassessment, all the same. So unstable every 5 minutes, stable every 15, and then just give them all the appropriate care that you would normally. Let's talk about some special concerns in pediatric care. There's a few topics here that we want to hit. All right, maintaining an open airway. This is like we literally just talked about a minute ago or so. For those younger kids with the proportionally larger heads, We're going to put some towels underneath there to help us put the head in a nice neutral inline position there. Head tilt, chin lift, no trauma, jaw thrust without. Can use suction, and we want to make sure that if we have an unconscious patient or a patient that's lost muscle tone, we want to check for the blockage of the airway by the tongue. Remember that tongue is much larger, proportionally speaking, in a child than it is an adult. It takes up a lot more room, so it doesn't take as much for it to block the airway. So we got to be aware of that. If we have a child that has lost muscle tone, is unconscious or unresponsive. In maintaining airways, we got this nice picture here of somebody about to insert an OPA into an infant. Now remember, the technique is different for an infant than it is for an adult. We can use a tongue depressor to keep the tongue out of the way, and we're not going to do that 180-degree turn, right? With an adult, we put the OPA in until it touches the roof of the mouth, and then we turn it around and drop it in. We're not going to do that for younger kids. These infants, younger children, the palate, the roof of the mouth, it's soft, and we can injure that if we did that. So we're going to put it in how it will eventually sit, and we're just going to follow that curve. So it is important to use that tongue depressor to get the tongue out of the way, so we're not pushing that backwards. And then that OPA will slide right in, pointing downward in the same position that it will be when it's fully inserted. We got a nice picture of an NPA. Take note that the child is the towel underneath the child's shoulders there to help keep their airway in alignment. All right, clearing and airway obstruction. All right, reach back into the memory banks. Let's go all the way back to CPR for clearing and the airway chapter that we did for obstructions. So two types of obstructions. There's the partial obstruction and the complete obstruction. The partial obstruction, they're still going to be able to breathe, at least somewhat there, right? The airway is not completely blocked off. They're probably going to be coughing, drooling, have a hard time swallowing. We're not going to do any blind finger sweeps or anything like that. Okay, we're going to let the patient try to clear that airway obstruction themselves. If they're breathing, if they can talk, if they can cough, then we know that it's a partial obstruction, right? If there's air moving in and out, it's a partial obstruction. So get them in a position of comfort, give them some high flow O2, and transport them. If they have a complete obstruction, then we'll start our airway obstruction techniques to give clearance there. So if they're about up to 2 years old or so, we're going to do those 5 back blows, right, with the heel of our hand between the shoulder blades. Flip that baby over, and then do the 5 chest thrusts. Flip the baby over, do the 5 back blows, and so on and so forth until either that obstruction has been cleared or the baby goes limp and unconscious, and then we start CPR. Now with this picture here, everything's looking good, right? But what we do have to remember is that you think, let me ask you guys this, you think that baby, let's say this gentleman here is actually doing this work on this baby. Do you think that baby's going to be nice and calm if that airway is blocked off? No ma'am, no sir, it is not going to be. So the only thing that I would change here for this gentleman is I'd have him sit in that seat right there. It's going to be much easier to hold on to that baby, to balance the baby while he's hitting the back like that, flipping the baby over and everything, even if he's using proper technique. That baby's going to be moving arms around, going to be moving legs around. And last thing you want to do is drop this child on its head while you're trying to give it back blows and chest thrusts, right? So you should just sit in that chair and get that done. There's nothing wrong with doing that, right? It's a little bit safer there. Now, if you don't have anywhere to sit, then do it this way. Just don't drop this child. All right, so providing supplemental oxygen and ventilations. This is going to just be obvious. It's just like anybody else. Again, we do have to remember that cardiac arrest is often brought on by respiratory and airway issues. So um, give oxygen to these kids. High concentration oxygen should be given to anybody that's in respiratory distress or has inadequate respirations or is possibly in shock. Um, I think that's pretty obvious. A lot of kids might be afraid of wearing that mask. They may not tolerate it. So let's use a blow-by method. We can put the oxygen tubing like we just saw in that picture near their face, and so they can breathe it in. Or you can even put it in a cup. If you have like a cup on board the ambulance, you can take out the bottom of the cup, make a little hole, put the tubing through there, and have mom or dad hold it by the child's face. Or even using the non-rebreather. You can have the non-rebreather mask, and you can have mom or dad hold that near the child's face so the oxygen is blowing towards them there. Now, it's preferable that we get the mask on, but if you can't, then let's use a blow-by technique. Now, if we're giving ventilations, we got to remember that these little kids, they have smaller lungs than we have. And so we have to be careful of providing too much volume, right? Too much air. And we have to be careful of the force with which we put it in there. So remember, as soon as we get chest rise, stop. That's enough of a breath. You've gotten enough in there. All right, so use the right size mask and use the right size BVM. Remember, we go adult, pediatric, and infant. They get really tiny, right? So use the right size mask so we get a good seal. Use the right size BVM. And then as soon as we get chest rise, stop. FROP BD is, if we remember correctly, is contraindicated for infants and children. It's that manual, you press the button and it forces air down the airway, that positive pressure ventilation there. It's just too hard. It can go in too fast. It's too hard to gauge. You don't want to make a mistake and hold that button down too long or that trigger down too long, and you have overexpansion of the child's lungs or pressure injury there. That wouldn't be good. So FROP VD is contraindicated for infants and children. Now, if we have issues getting chest rise, again, remember that distension can prevent a good ventilation. All right. So that can happen. But also we got to think that if we're not getting air in there, and we've got a good airway maneuver going on, right? We've got a good head tilt, chin lift going on, or jaw thrust, and we're not getting anything in there. Think about maybe there's an obstruction going on. So go ahead and try to clear the obstruction using the proper methods: back blows followed by chest thrusts, and then try to ventilate again. Again, here's that same picture, a little kid getting the blow-by method. Use the right size mask. This is somebody being ventilated with a pocket mask. Again, if you have to use these, make sure you stop when you see chest rise. All right, caring for shock. This is just the same as adults. Some of the more common causes for children to go into shock, remember, they're smaller, so their blood volume is less. Their overall body water volume is less, and so they have to lose much less blood or water in order to be hypovolemic. So if a child has been having diarrhea or vomiting for quite a while, they can be severely dehydrated and they can be go into hypovolemic shock. If they have an infection, if there's trauma, especially with abdominal injuries, and there's internal bleeding, if there's any kind of bleeding there, they can have allergic reactions, poisonings, cardiac events, things like that. So all the same reasons that adults can go into shock. All right. Caring for shock, it's going to be just the same. We're going to make sure the airway is open. We're going to make sure that they're getting high flow O2. If there's any bleeding, we're going to stop that. We're going to try to control that. Going to keep them supine, going to keep them warm, and we're going to get them to the hospital immediately. Just the same as adults. All right, as we talked about at the beginning with the A&P review, the kids have a more difficult time. The younger they are, the more difficult time they have in maintaining their body temperature, and so they can get hypothermic more easily than adults can. So make sure you cover their big old noggins, right? Cover their heads, cover their bodies, give them a blanket, sheets, towels, whatever you got. Turn the heat up in the back of the ambulance if it's wintertime. Or if it's summertime, maybe turn the air conditioning down, let it get warm in there. If you remember back to our environmental emergencies chapters, we don't want to treat a hypothermic patient roughly, so avoid the rough handling. That can bring about cardiac arrest issues. And then consult your protocols or medical direction about if we can actively rewarm these people. If they're still shivering, you can probably actively rewarm them. If they've stopped shivering at that point, you probably won't be able to. But always consult medical control and be aware of what your protocols are. All right, let's talk about some medical emergencies for these kiddos. As we've said 9 bajillion times, with respiratory and airway issues, um, they're the most likely cause in pediatrics for cardiac arrest. Okay, so we have to try to distinguish whether the problem is upper or lower airway, and we can do that usually with sounds. Right? So what sounds are upper airway? What sounds are lower airway? What do you think? Wheezing, is that upper or lower? That's lower. What about stridor? Is that upper or lower? It's upper, right? It's an upper airway obstruction that causes that. Um, excuse me. Be aware that if of their work of breathing, if we've got like the nasal flaring and retractions, it means they're really working hard. And we have to remember their chest walls are not as developed, and so they're not going to be able to really work hard to breathe for a long time. So respiratory distress can easily lead to respiratory failure. And so be really aware of that. Okay, we have to be aggressive with airway and respiratory management for kids. So if we're seeing signs of respiratory distress that could lead to respiratory failure, we got to get in there with some supplemental oxygen, and we're probably going to be in there providing PPV, some positive pressure ventilations with the bag valve mask. We're going to cover in just a little bit a couple of airway issues, respiratory issues with kids that we haven't yet before. There's a number of reasons why any patient, including kids, could have difficulty breathing there. So they can be as simple as a cold. Remember, if they get a head cold and their nose is all stopped up and they're very young, they might have a difficult time breathing because they're obligate nose breathers. And this last point is important here, right? It's real important, this last point here. Whoops, nice circle. We have to recognize the signs of respiratory distress early, all right? Early, because problems just cascade from there. Once they get into respiratory distress, if it starts to leading towards failure, then we have respiratory failures on the table now, and that could possibly lead to cardiac arrest. So we have to be aware of all that stuff there. So it is ultra important for us to know the signs so we can recognize it early. All right, so let's talk about some upper airway issues here. It's important to differentiate, to be able to know the difference between an upper airway versus a lower airway problem. Upper airway problems can be caused by foreign body obstructions, right? Somebody's choking on something. They can be caused by trauma, swelling from infections and burns, among other things. They're commonly identified by some sounds, right? So stridor is that sound. Difficulty speaking, right? One or two word sentences can do that. Another sound, though, would be hoarseness in their voice, right? If somebody has suffered burns to their airway, then the voice is going to get raspy and hoarse, and it may progress and get worse as we're with them. So that's another sound there. All the signs of difficulty breathing that we know as well can help us identify that too. As you know, hopefully you know this, and this is just redundant, but um, the upper airway includes the nasopharynx, the oropharynx, the mouth, the throat, there, all the way down to the larynx. So lower airway disorders, this is going to affect the large and small bronchial tubes and the alveoli. So basically everything below the larynx. Um, Pneumonia, asthma, and there's other infections, right, like bronchitis, can all cause issues in the lower airway. And wheezing is a big sound for us that indicates lower airway problems. What are some other sounds that we can hear that would indicate lower airway? And when I ask this, I'm particularly talking about when we auscultate. Well, we're talking about rhonchi, right? That thick, gurgling, bubbling air moving through like thick mucus down there. We've got the rhonchi. It's kind of rough, that sound. And then we've got the rails, right? The crackling, the snap, crackle, pop, the Rice Krispies that we can hear. It's like a thinner fluid that's down there. We have something like that. We can also auscultate the wheezing, right? So those are indicative of those lower airway problems. All right, so other assessment things that we can see, other signs that we can see for respiratory distress. We've got nasal flaring, abdominal, or excuse me, just retractions above the clavicles, in between the ribs. The use of the secondary use of abdominal muscles. They become, we get more of that seesaw breathing. They become more of belly breathers there. It's like bringing in extra help to help move air, right? They're already getting tired, and so they're bringing in other muscles, a part of their body, to help them bring in that air. Okay, so if they're starting to use those abdominal muscles, you can already figure, or more so using those abdominal muscles, you can figure that they're already getting tired. Stridor, we know what that is. It's a high-pitched, whistling, kind of harsh sound that's indicative of an upper airway obstruction. Audible wheezing, grunting when they're trying to exhale, just trying to get that air out of there. All right, the grunting. Breathing greater than 60 breaths per minute. Holy moly, is that fast? That's greater than 1 breath per second. So they can't be that deep if they're going to be that fast, right? Now, even neonates don't breathe that fast. They'll breathe up to about 40 times a minute. So 60 is so fast. So if somebody's breathing, even if they're a neonate, that quickly, that's trouble, right? They're not getting the volume that they need there through that. An altered mental status obviously can come from hypoxia. If they have a slow or irregular respiratory rate, right? These younger kids, they're normally breathing faster than us, and so if it's slow, that's indicative of a problem. And an irregular rate, the breathing pattern is irregular. Well, that's weird. That's off, right? We breathe normally, in, out, in, out. Usually it's the same depth and the same rate, right? We're usually pretty even about these things. So if they have different respiratory patterns, rather, then that's an issue. If they're cyanotic, that can be in the face, the extremities, centrally cyanotic, especially for the neonates there. If they have decreased muscle tone, if we can't get good cap refill in their fingers and their toes, so we know there's a problem. They have poor perfusion, blood and the oxygen's not getting pumped all the way around the body, and a decreased heart rate. Again, with the vital signs of a kid, we know that these vital signs are normally higher than they are as adults. And so if we have a decreased heart rate, that's indicative of a problem. It's normally going to be higher. All right, let's talk about some respiratory diseases that will be new to you. So make sure that you know, at least this one. The next one you guys already know. But this one is new to you. It's called croup. It has symptoms that differ daytime versus nighttime. It generally gets worse at night. So during the day, they can have a mild fever and some hoarseness during the day. At night time, the hoarseness is gonna get worse. Their throat's gonna be hurting. They're gonna develop this loud cough. This it's a loud. It's like a seal bark. It's like a seal barking cough. They're going to have difficulty breathing. They'll have all the signs of respiratory distress. And they're going to be restless. They're going to be trying to get themselves into a position where they can breathe well. And so they won't be able to lay down. They won't be able to sleep. They're going to be trying to position themselves for this thing. Now, this infection, it's a mild, or doesn't necessarily, not necessarily mild, but it is a viral infection. And it affects the upper airway there. So what we want to do is obviously transport these kiddos to the hospital. And in doing so, what we can do, what's cool about this is that cooler air helps to relieve some of these symptoms at night. So what we can do is when we're moving the child from the home to the ambulance, in that little space of time, maybe walk a little bit slower. Let that kiddo breathe in some of that cool night air, and it's going to help there a little bit. Okay. Excuse me. Now, don't delay your transport just to hang out outside at nighttime, okay? If you need to, maybe open up some windows in the back of the ambulance. Let them breathe in some cool night air there. You want to give them O2. If you can, humidify it, but again, don't delay any transport to try to get the oxygen humidified there, but that would be preferred there. Position them. It's probably going to be sitting up, maybe in mom and dad's lap, sitting up like that. But that's what croup is. So it's a little bit milder during the day. Symptoms get worse at night. And the last one we want to talk about is epiglottitis. We know what this one is. This child is going to have a sudden onset of fever there. And this is, just to back up a second, this is normally a bacterial infection. They're going to have sudden onset of a high fever. The epiglottis is going to be swollen. Okay, we all know what the epiglottis is. And so because the epiglottis is swollen and painful, it's really going to hurt to swallow. And when I say it's really going to hurt to swallow, I mean it's going to hurt to swallow anything, which is why they will often be drooling. They'll be found to be drooling. Because of the swelling there, we're going to have some difficulty breathing a little bit there, and it's going to, they're probably going to be presenting in a sniffing or tripod positioning there, try to open that airway, keep that epiglottis off of the airway there, and the patient's going to be sitting very still. Now, these kiddos are sick. They're going to appear more ill than the kids with croup. They're going to have, again, a higher fever. We all know, we've all been sick, right? We've all had bad fevers, but we all know the difference between having a fever that's, 100 degrees versus one that's 102 degrees. So the fever is going to be higher there. So they are going to appear more ill. Now, again, we've covered this. So just as a quick recap, we're going to move with purpose with these kids, but we're not going to be like rushing around, all that much, right? We want to contact ALS for this in case there needs to be intubation. We want them to be transported immediately because if this epiglottis gets too swollen, it can cut off the airway. Have them sit on mom or dad's lap to keep them calm. We don't want them crying, anything else like that. Just try to keep them nice and calm, okay? We want to provide high flow O2 to these folks. If we can, humidify it, but again, don't delay transport to humidify any O2. Watch for respiratory distress. Constantly maintain that vigilance on their airway. Don't give them anything by mouth. Don't put anything in their mouth. Be gentle with them. Don't get them real upset. Let's be nice and easy with them. Doing so, putting anything in the mouth, if they're crying, that kind of thing, real loud and kind of freaking out and all that kind of stuff. What could happen is it could set off spasms along the upper airway, and if that were to happen, the airway could be completely obstructed, and then we're in a whole different world of hurt at that point. All right, so nice and calm, move with purpose, transport them immediately. Let's keep them calm, keep them with mom or dad on the seat there. Let them sit in a position of comfort that's going to be upright or more of a tripod position probably. Give them some blow-by oxygen and get them to the hospital. Right? Make sure you do have you rendezvous with ALS or get them to the scene as soon as you figure this out. All right, so let's talk about some other things with kiddos. Fevers, obviously, fevers are common with kiddos. They get sick all the time. All right, so kiddo with a high fever, we're going to remove the clothing from them. All right, to let some of that heat radiate out into space. Cover them in a towel that's soaked in tepid water, if you can, according to your local protocols. And when they say tepid here, what they basically mean is room temperature. Okay, maybe a little warmer than room temperature. Don't give them a cold towel. Don't give them like a freezing cold towel. Remember, kids are much more susceptible to being hypothermic than adults, and so giving them a cold towel, freezing cold towel, then that's not a good idea. Monitor for shivering. If they start shivering, then they're probably, despite the fever, going hypothermic there. We may be able to give them water or ice chips. A lot of places don't allow anything by mouth to patients, so make sure that wherever you're riding, you're following your local protocols for that. As we covered in our altered mental status and seizures chapter, a child with a high fever, a fever that has spiked very quickly, can have what's called a febrile seizure. And the cause of that is that spiked fever. So if your patient has had a fever, regardless of whether they're still post-ictal or they're normal to mom and dad, they just have the fever, you still want to transport them. All right. Don't dunk them in cold water. Don't throw them in a bathtub, with freezing cold water or anything like that. And like later in life, way later in life, if you all are ever parents, and you have your own kid, don't get in the tub in the middle of the night in a freezing cold tub. Again, they can go hypothermic because of that. All right. So any water that you apply on them, the coldest it should be is room temperature. And don't use rubbing alcohol to cool the patient. Basically what it is people will put rubbing alcohol on the baby's skin, and that basically acts as a sweat. It absorbs some of the heat while it's on the skin, and then it evaporates, just like sweat does. But doing so, again, can help push that patient towards hypothermia. Also, a lethal or a large amount of that rubbing alcohol can be absorbed into the skin, and that is not going to be good for that kid. All right, for a few more other pediatric disorders, let's talk about meningitis. If we remember back to the neurological chapter, meningitis is an infection, either bacterial or viral, of the lining around the brain and the spinal cord. This can be a serious and life-threatening infection, and for kids, it's most common in basically 1 to 5 year olds, but it's not uncommon to see it in adolescents. Personally, I had a friend in high school that got it, and she died of it. So she was a senior when I was a junior. So 17 years old about. So it is not uncommon. However, it is more common in 1 to 5 year olds. So some of the signs and symptoms of this: high fever. Anybody with meningitis, they're probably going to have a stiff neck. All right, so get them to move their head around from side to side, up and down, see if they report any stiffness there. They'll be lethargic, irritable, probably have a headache. They'll be sensitive to light. In infants, they'll have bulging fontanelles there. unless of course the child's dehydrated, then it'll be sunken a little bit, but there'll be movement will be painful as well. Remember, it's down the spinal cord too, so the child may not want to be touched or held. They could have seizures. This could produce seizures there, and if it's a bacterial infection, they could have a rash there as well. So, care for this. It's actually pretty simple. Um, Obviously, like any other patient, monitor the ABCs, vital signs, right? Monitor, do the vital signs every 5 minutes. Let's get those trending. High concentration O2 with a non-rebreather if we can, otherwise do the blow-by. If necessary, provide ventilations, CPR, be alert for those seizures and how to handle that, and transport them immediately to the hospital. All right, diarrhea or vomiting. The problem here is that the kid's going to get dehydrated and maybe very quickly. Remember, they don't have to lose a lot of water to get dehydrated. So obviously maintain an open airway. Be prepared to suction if you need to. Be prepared to provide oxygen if they're showing any signs or symptoms of shock. Care for that. Lay them supine, high flow O2. If they're actively vomiting and you can't lay them supine, lay them like left lateral recumbent. Okay. Make sure that you've got suction ready to clear that airway there. And again, if your protocol allows it, ice chips, clear liquids, water, okay, not like soda or anything else like that. And transport them immediately. For seizures, same as an adult here. Seizures, excuse me, are usually a sign of something else. Okay, so be aware that you look for something else. Like, is it a high fever? Did they ingest something? Were they poisoned? Things like that. Okay, maintain the open airway. If you need to use an adjunct, we're not using an OPA, right? We're not going to put anything in their mouth. Use an NPA if you have to use an airway adjunct. Be alert for any vomiting. That's possible. If it occurred and there could be the possibility of a spinal injury, be aware that you may have to take spinal precautions there if there's a head injury or neck injury. And then watch out for their mental status. Okay, obviously, if you get there while they're seizing, they're going to be in altered mental status. After a while, after they've done seizing, and for a while, probably they're going to be post-ictal or have that altered mental status in their post-ictal phase. And so hopefully it progresses and gets better as time goes on. Watch for changes in that, and watch for changes in their breathing. Patient's not going to be breathing correctly if they're going through having those grand mal seizures, right? They're not going to be breathing well. So hopefully after the seizures stop, the breathing rate, depth, and all that returns back to normal. So be aware of altered mental statuses and their breathing. So for a kiddo with altered mental statuses, all right, let's see if is it going to be trauma? What is going to be causing this? Look for signs of shock, right? Are they hypoxic? Are they breathing well? Are they bleeding? Have they poisoned themselves by ingesting like a medication or a household cleaner, something like that that's given them this altered mental status? See if there's a history there, if you can. Is there diabetes? Do they have seizures? Anything like that. For poisoning, we went through that poisoning chapter, so everybody should have poison control, the number to poison control in their telephones. Now, if a patient has ingested something, pediatric patient, one, figure out what it was, how much they ingested, and when they ingested it. Contact the hospital for medical direction and contact poison control as well. Give them a call. Most places nowadays aren't letting field units, even though it might be in the protocol, they're not allowing field units to do activated charcoal. They'd much rather do that at the hospital there. A lot of places don't even carry activated charcoal anymore. Give them O2, transport, and continue to monitor their responsiveness. Again, this is going to be a continual assessment, right? What does their mental status look like? If they've ingested a lot of, let's say, sleeping pills, maybe they're alert when you've gotten there, but by the time you're getting to the hospital, they're lethargic or they're unresponsive by the time you get to the hospital. So there could be that change. Maybe it's gradual, maybe it's quick, but just be alert for it. And be vigilant in monitoring things like their responsiveness. And again, because they're kiddos, be aware of their respiratory rate and how they're breathing. That could change as well. All right, so caring for the unresponsive patient after a poisoning, all right, make sure the airway is open. Provide O2. Okay, if they're unresponsive, we'll be able to get that mask on them, right? We may need to do some artificial ventilation with supplemental oxygen. Um, Make sure that you're ready to suction because vomiting could occur. So be ready for that. So keep that airway open. Use all the tools that you have to keep that airway open. Positioning, right? Left lateral recumbent maybe. Suction, have that. And if you need to, then provide ventilations as well. Again, contact medical control and poison control center and get to the hospital. Make sure that this is in fact a poisoning and it's not something else that's causing this, like a trauma. Like we talked about, so this is a drowning patient rather. All right, so for drowning patients, once they're out of the water, you're not going to be able to do CPR in the water. But once you get them out of the water, you can start to provide CPR. When you're in the water, if you need to, you'll probably be able to give them breaths. You'll probably be able to do mouth to mouth in the water there. Protect their airway. Consider if this is trauma, right? Did somebody dive into a pool and they hit their head on the bottom, knock themselves out? Maybe they had a compression injury to the spine. Consider that spinal immobilization if there's a mechanism of injury here. Maybe it's not just a kid that isn't a strong swimmer and got lost in the crowd, basically in a crowded pool, and they went under. They're going to be wet. If they're younger, they're going to, protect against the hypothermia there. So get them dried off, treat any transport. Now, what's important to know is there's something called that's near drowning, and that's where somebody might go unconscious in the water, like a child. They're brought out of the water. Basically they're revived. Maybe it's somebody shaking them awake or whatever it may be, but they come back. All right, and by the time you get there, they're alert, they're responsive, they feel fine. Mom and dad are shaken, but we're just so glad he's okay, he's fine now. That kind of thing. Those patients need to be taken to the hospital. What can happen is what's called a dry drowning, and that can happen either minutes or a few hours later, where their condition starts to get worse and they develop problems because of what happened, like in that pool or lake or whatever. So if there's something like a near drowning, those patients, even if they're like doing A-okay by the time that you get there, they need to be taken to the hospital. They need to be under observation at the hospital. Let's talk about SIDS here. This is sudden infant death syndrome. What this is a normal, healthy baby, right? SIDS happens normally with normal, healthy babies. It happens to about 2,000 and 3,000 kids a year. These kids are usually between newborns and about 1 year old. These are normal, healthy babies, and for some reason in the middle of the night they die. There's no good explanation for this. There's no good scientific or medical reasoning why these kids die. They may have gone to the doctors, that week and had a checkup and everything was great, and then, a few days later, mom and dad wake up in the morning and the baby's dead in the crib. Okay, so no good reason for this to happen. Now, if you get called for this, you're going to be treating it as any other cardiac or respiratory arrest. All right, so treat it as respiratory arrest, obviously, if there's still a pulse. Cardiac arrest if there's not. But you're going to do that unless, right, we're going to start resuscitative efforts unless there is rigor mortis present. And what that means is that that's when the body stiffens. If rigor mortis is present, The patient has been dead too long to be brought back. Okay, it is way too long. A lot of processes have happened, have stopped happening, etc. in the body, and it's just too late to bring them back. So start efforts unless there's rigor mortis present. As you can imagine, this would be one heck of a devastating morning for any patient or parent, rather. Um, so be prepared to give emotional support. Um, I couldn't imagine how difficult it would be and all the feelings that would go surging through you, guilt and everything else, if confusion, anger, whatever it might be there. So be supportive of the patient of their feelings. Be aware that it's going to be a very highly emotionally charged scene there. Maybe they're going to be angry at you, things like that. But um, uh, don't be afraid to support them emotionally, to offer your condolences and things like that. Now, you may suspect that it's SIDS and things like that, but don't give your field diagnosis, to them there. But be supportive of them. I mean, I just couldn't imagine. Just an absolutely devastating event there. Normal, healthy kid, for no good reason or none that anybody can find, dies in the middle of the night. All right, let's talk trauma here real quick. All right, so some injury patterns during motor vehicle collisions. If they're unrestrained, just like an adult, you're going to get head and neck injuries here. Now, we'll talk head injuries just for a second here, because we kind of skipped over it earlier a little bit. With head injuries, again, their noggins, they're just huge compared to their bodies and compared to adults, proportionally speaking. These big old melons on their heads, right? Big bowling balls up there, big and heavy. But what happens inside their head, their brain hasn't really, completely developed and grown, so there's more space inside the skull there for that brain to move around. So it's easier for that brain to get hurt while it's in there. So we can have head injuries because of that. We can have neck injuries because that head is so big, and the neck and supporting muscles and bones haven't developed and grown stronger yet. So it's easy for that to happen. When they are restrained, we're going to see abdominal injuries where the seatbelt goes across their lap and the lower spinal column as well. When they're hit by a car, we got to remember, most school age kids and things like that, not much of their body might come above the hood of their car. So the whole grill, front grill, the bumper, and all that's making contact with, their like basically their entire thorax, maybe their head too. So we're going to see head injuries, chest injuries, abdominal injuries, pelvic injuries. We can even see extremity injuries, particularly the fractured femur. So when a kid gets hit by a car, whether they're riding their bike or they are walking on the street, because they're just so small, all that stuff from the car is going to be making contact with their body. So we can expect to see lots of injuries from head basically down to the knees or so. She looks like she's okay. She's got a little purple helmet on. She's doing all right. All right, again, the head is bigger, it's huge. So when forces are applied to the patient's body, that head can whip around pretty good. Either hyperextension with whiplash or hyperflexion going forward there, or even side to side. With kids, look at this, respiratory arrest, common secondary effect of a head injury. Right? Gosh, all this respiratory arrest that we got to be worried about with kids, right? Man, there's got to be a reason to keep bringing it up. It's because it happens. So we've got to be worried about respiratory arrest there for kids. The chest, when there's chest injuries, right, we're going to have real problems here because the chest is less developed. The muscles in the chest are less developed. That chest wall is more flexible. It's not as rigid, and the muscles aren't as developed. And so when they get injured, it makes it that much harder to breathe. If we got deformities, bruising, or anything like that along the chest, that's indicative of injuries below that level. So we can have problems with the lungs, the heart, the great vessels that are in there, even the diaphragm as well. So uh, the only difference here in examining the children's head when we're doing a physical exam is check the fontanelles in infants. All right, up to 2 years old, check the fontanelles. And again, don't press into a fontanelle, but just check that we don't have crepitus, things like that, that it's not bulging, that it's not sunken. Check the eyes, that should be the same. Checking the neck is the same. Checking the chest is the same. Checking the abdomen is the same. The contents of their thorax, shocker, it's the same as everybody else, right? Assessing for breath sounds, basically be the same. For the abdomen, we're checking for injuries there. Again, distension, tenderness, rigidity. Um, if we have distension there, remember it can interfere with their work of breathing. Um, watch out for vomiting as well. Extremity injuries handled the same as adults. We'll just splint those in the proper manner. Assessing the abdomen, it's exactly the same. Things that we're looking for is exactly the same in kids. And here's the contents of a child's abdomen. Shocker, it's the same. Checking the pelvis is the same, just like we're going to close a book. Checking the arms is the same. The only difference here when we're checking the extremities is that we're going to also check for cap refill. All right, immobilizing with a KED. So if you don't have a short backboard or a pediatric backboard, you can use a KED. You just get the C collar on the kiddo like that. Log roll them onto there, get them positioned like that, and then you're going to close it on them there. Now, the straps are going to be way too long. It's not going to be able to efficiently or correctly hold that child in place. So you're going to have to tape around that bottom section there rather than using the straps. All right, burns. Go back to your burns chapter to recall what burns may require burn center intervention rather than just normal hospital transport. Treating burns, a dry, sterile dressing. Make sure the airway's open and it's going to stay open. Remember the signs of airway burns, raspy voice, soot around the nose, the mouth, burnt facial hair, that kind of thing. Suction as needed. Mobilize the spine if you suspect any injuries and get them to the hospital. All right, let's talk about a little serious matter, child abuse and neglect. There's several types of abuse, but they often happen in common. It's not often that a child in a home is just sexually abused. There's often going to be other physical abuse. There's probably going to be psychological abuse that goes along with that as well. So oftentimes different types of abuses go hand in hand, and also neglect there. Neglect is it's hard to prove in court about what constitutes neglect, but it's kind of one of those things where you know it when you see it, but it's definitely hard to prove. So the types of abuse that we're going to be looking at: psychological abuse, sexual abuse, physical abuse there as well. Um, now, there's the physical and sexual abuse that can happen. There are just some real, monsters out there that will inflict any type of imaginable pain or horror upon a child, right? And these people should be buried underneath the jails and all that, right? They are out there. Um, these kids are often called battered kids. The sexual abuse can range from something like an adult exposing them, all the way up to rape and sexual torture of children too. Like I said, there's just some monsters out there. Um, Now, this is tough for kids, right? Who are they going to trust? After an adult, probably somebody near them has done this to them. Who can they trust? So cases often go unreported, and things that may be considered "quote unquote" more minor may go underreported or not reported at all, unfortunately. So there's lots of different signs of abuse. So slap marks, right? Bruises like in the shape of hands, bruises, cuts, lacerations, scrapes, incisions, broken bones, head injuries, abdominal injuries, bite marks, burn marks, indications of shaking of an infant, somebody violently shaking an infant, right? So all sorts of things. I mean, people do crazy things like they'll burn kids with cigarettes or cigars. There's things called dipping burns or injuries where you have a pot of boiling water and they'll dip a kid's hand or foot into it. They're called glove burns or a stocking burn because the burn looks like the kid is wearing a glove. And you can always tell this because there's the entire hand, let's say, would be burned, but like right at the wrist, there's a clear line of demarcation between the skin that is burned and the skin that is not. And obviously, it goes all the way around the hand. The whole hand is burned. And like those are abuse injuries there. Um, so those can be some signs of possible physical abuse. In this picture, we see a child that has been, hit or spanked, whatever it is, and if you look closely, you can see that there's new bruising or more recent bruising, and there's old bruising. So this child has been hit repeatedly on separate occasions. This child, apparently a teenager, this is from a cord whip, so like an electrical cord that they got hit with. And that's healed over a bit. So, and it still looks deep. So, I mean, this is somebody hitting somebody with an electrical cord, a kid with an electrical cord. So, it's out there. People do just monstrous things to kids. All right, so some signs of possible physical abuse. There's obvious signs of sexual assault there. Unexplained genital injuries can happen. Now, if this is the case, um, or excuse me, before we get there, there could be semen on the body or on clothes or other discharges that could be associated with STDs or STIs. Um, if the kid tells you, I've been sexually assaulted, that's a pretty good sign for a child that's been sexually assaulted, right? Thank you, Captain Obvious, right? Yeah, so believe the child when they tell you that. So when we're there in the home and we suspect something, um, we have to be looking at the adults that are around that kid. Right? We are uh, mandated reporters. We are obligated to report findings that we suspect of child abuse to the proper authorities. So, Child Protective Services and attending physicians at the hospital and whatnot there. Um, Adults, they may not be really concerned about the kid, or maybe they're really highly charged emotionally, like they're really angry. Maybe they seem like they're about to explode. Like you can feel that when somebody's done that. I'm sure we've all been around somebody that's been like that, from one reason or another. That's been just on the verge of an emotional explosion. Um, Somebody maybe that's deeply depressed, if there's signs of alcohol or drug abuse, if they express suicidal thoughts themselves, things like that, that can be a reason to maybe indicate that the adult was an abuser. Um, so for the patient care here, all right, so make sure they're dressed for, provide them with their dignity and keep them dressed. Provide appropriate care for any of the injuries. Now we have to be aware of preserving the evidence, so don't let them go to the bathroom. Uh, don't let them change clothes or bring those clothes with you. But don't let them. I wouldn't let them change clothes. Don't let them wash the clothes. Don't give them anything by mouth and get them to the hospital. Now, if you do suspect something, one of the things that some child abusers might do is they might purposely hit children in areas that clothing normally covers. So maybe they only hit them with, the cord on their back, something like that, or somewhere else where clothing might normally covered. So be aware if there's injuries in strange spots, or if the injuries don't quite match up to the statements of how that child got injured, like the mechanism of injury doesn't make sense, right? Then be highly have a high index of suspicion there for that kind of thing. One thing to note, in many areas, ours included, when there's injuries to a pediatric patient in a home, uh, normally a police officer is dispatched as well, right? Just in case there's any signs of abuse there. Normally a police officer is dispatched as well. Right, so what do we do with these adults there if we suspect them, right? So we're going to be like kind of detectives and information gatherers there, okay? Try not to, you know, call out lies if you suspect that they're lying. Don't accuse them of anything while you're there. So reserve your judgment. Be cool, calm, and collected. If you can, talk with that child separately, although they may be too afraid of consequences to tell you anything. So just be aware of that. When you tell your story to the police, to the hospital, to Child Protective Services, whomever you're talking to, or whoever or when you're writing your report, use plain and clear language about that. Also, use terms like possible or suspected or things like that. Okay. Remember when you're that legal document that you're writing, that report, that patient care report, just write, suspected child abuse or possible that the father was involved or blah blah blah. Right. Be careful about libelous statements there. And then obviously we're going to talk to CPS, Child Protective Services, and the abuse hotline there. All right, infants and children with special needs. We'll talk about this real quick here. All right, so there's some common challenges with these special needs. Premature infants, like we talked about in the last chapter, they may have breathing issues. Their infants and kids can have congenital heart defects, right? Heart defects that they're born with, heart conditions that they're born with. They may have neurological diseases that they're born with. They may have other chronic or altered function diseases that they've had since birth. All right, and so many of these kids will have specialty equipment at home, like a home ventilator, etc., at home, and we need to be aware that while pediatric calls represent overall a smaller number, a smaller portion of the calls, these kids represent a higher number of the pediatric calls. Okay, all these diseases that they've had over their lifetime, it results in them going to the hospital and getting emergent care more often. So they may have a tracheostomy tube. Tracheostomy tube, if we remember, is a tube that's put into somebody's trachea. This is if they've been on a ventilator for a long time. These can become obstructed. They may be infected. There may be some swelling. There may be some bleeding from or around the tube there. It can be dislodged from there. And our care with that is just going to be basically suctioning it out, providing oxygen if necessary, and transporting. A note about like some of these machines and devices that they may have implanted in them. We're not going to learn about all these things. We're not going to learn how to use a home ventilator, things like that. However, their mom and dad or their grandma, grandpa, whomever their caregiver is, maybe they have a home health aide, a nurse, or somebody that comes in to help. They're going to be experts on the machines that they use. So don't be afraid to say, how do you use this? Or make sure that this is good. Okay? Don't be afraid to say that. We're not trained on every device out there. So don't be afraid to speak up and say, hey, you know how to work this. I need you to come with and work this machine if necessary, right? So don't be afraid of doing that. There's again home ventilators there. Now, what you're going to have to do, most of these are not going to be portable. So you're going to have to take the patient off of the ventilator, off of the machine that's breathing for this patient, and then you're going to have to breathe for them using positive pressure ventilations, right? So bag valve mask, you can usually hook it up right to the tracheostomy tube there and ventilate them, all right? So just be prepared to be ventilating for a patient the entire transport to the hospital. There's central IV lines there that are implanted, so they can be infected, they can be bleeding at the site, They can be broken. They can be clotted off. They can be blocked. Um, the only thing that we can do with any of these problems is if there's bleeding, we can apply pressure to the site to control the bleeding and then transport the patient. If we're noticing any signs and symptoms of anything else, then we can give oxygen as needed, etc. Right? So just be aware that there could be other things going on there. If they have a central IV line, they could have other underlying complications or issues that are going on. Here's a picture of a gastric feeding tube. This is basically a hole that's put in the abdominal wall, and a tube is uh, surgically inserted directly into the stomach. So this is for somebody that can't feed themselves. They can't use the upper part of their GI tract, and so their food goes directly into their stomach there. So um, with these kids. Uh, what you want to do is be alert for an altered mental status. Okay, we got to know if they're diabetic, right? If they're diabetic and this isn't working, and we have a problem here, maybe they're not getting fed correctly and they're going hypoglycemic. So that means an altered mental status, maybe seizures, things like that. So be aware of that. So make sure the airway is open. Have suction ready as needed if there's any vomiting, anything else like that going on. Provide O2 like any other patient as needed, and then transport sitting or on their right side or left lateral recumbent with their head elevated a bit. So if there is vomiting, we reduce the risk of aspiration. All right, shunts are basically little drainage tubes that go from the brain, the skull, down into either the abdomen or one of the atria of the heart. What it does is it's draining excess cerebrospinal fluid. If for some reason it gets clogged or broken or dislodged, something like that, what's going to happen is there's going to be an excess amount of cerebrospinal fluid in the brain, which is going to increase intracranial pressures there. So we can have altered mental statuses there. There can be an infection at the insertion site, so that can produce an altered mental status as well. So be aware of their breathing there with the increase in intracranial pressure. Be aware of their breathing, ventilate, give oxygen as needed, and transport. All right, let's talk about the EMT, and how we handle these emergencies. Um, I won't joke with you here. A lot of times, sometimes pediatric calls they are not fun, especially if that kiddo is really sick or really hurt. They can be incredibly stressful. Personally speaking, they were stressful before I had a child of my own, and now that I do have a child of my own, they're more stressful because it's hard not to look at a child that's hurt or sick that is my child's age and not see her in my patient there, and think about that. So they are difficult calls. They're among the most stressful, and they are among those that can last longest with the EMT, like in their mind. So not only does it affect people seeing kids sick and hurt, some people might be really anxious about talking with a child. Maybe they don't have a lot of experience. Maybe they don't know a lot about kids, or don't think they know a lot about kids. Like how to talk to them. How do I've never spoken to a child before. Maybe they are anxious about dealing with kids. Um, and so that can be an issue with people. And obviously, those more serious calls are more stressful there. So the really sick kid, the really hurt kid, the child who dies on the call or after the call those can be really stressful times that stick with you. So we always have to remember that our health and safety is priority number one, not only on the call, but after the call too. So if you have one of these tough calls out there, you have a kid that, I don't know, reminds you of your little brother, your little sister later on in life, it reminds you of your own child, or it's just tough treating and seeing a really sick, a really hurt kid, a kid that's dying. Um, Talk with other people that have been there. Talk with other EMTs. Um, activate, get your the critical incident stress management team, the SISM team, going at the station that you're at. Your station may have counselors on call that aren't part of SISM, or maybe they are, but they don't. You don't need the whole SISM team. There's resources for you. Heck, I'll be a resource for you guys. You can always talk to me, and I'll get you pointed in the right direction with this kind of stuff. All right, so don't keep it in. Talk about this stuff. Your health, your safety is always number one, and that again, that includes your mental health off duty. So if you these pediatric calls can be real tough, and they can stick with people for a long time, and they can affect people. So don't be afraid to talk to somebody. It's not a weakness. It's a strength. If you go out, if you have an issue and you actually go seek to fix it. If you have an issue, that's a strength. That's not a weakness. Unfortunately, in our line of work, it has been seen for a long time that, oh, I can just handle anything, and people don't get hurt, or they don't get help for themselves, and it hurts them in the long run. I think that is starting to change for the better. So again, if you need help, ask for it, whether through the company you're riding with, through your station, whether you want to call, give me a buzz, and I'll get you pointed in the right direction. Whatever it is, talk with your partner, whatever it might be. Take care of yourself with that. These can be definitely trying times. All right, that's the end of the chapter. Just over 2 hours there. Sorry about the length. This was a long one. We tried to get through it quickly and pack as much in as we could without missing too much there. If you have any questions at all, please let me know. Either shoot me an email or have it ready for me when we do our review. All right, take care.